Hello, everyone. We are at the top of the hour, so I would like to take this moment to thank you for coming to this community table today. This is a discussion that brings together two of the World Vision International Communities of Practice, the Global Health, Nutrition, and HIV community, as well as the Humanitarian and Emergency Affairs Community of Practice. We've also invited peers from our peer networks to join into this community discussion today. So welcome to all of you who are both inside and outside of World Vision contributors. Addressing the health and nutrition needs of populations affected by disasters has always been a priority for World Vision. And a new World Vision Health and Nutrition Emergency Response Framework has been in discussion within this community for a while. How can we be better prepared for disasters in our various offices? So, in line with the Humanitarian Summit Health Consultation, the purpose of this framework is to outline World Vision's basic package of health and nutrition services in different types of emergencies, the types of interventions, and the technical approaches to be employed. This is a draft framework that is being presented today by members of the working group. I will put their faces here. We're having this webinar at 2 different times so that we can reach the various parts of our partnership. So today we have Dr. Mesfin Teklu, who is our partnership leader for Global Health and Nutrition, and Emma Littledike, who is our WVI Senior Emergency Nutrition Advisor. At the time number 2 call, Claire, who's based in Australia, will be presenting at our time number 2 in about 13 hours from now. So Mesfin and Emma have been working through this framework with the working group and are looking forward to presenting and getting your feedback and listening to this discussion today. But before we begin, a little housekeeping. You will note that as you came into this webinar, you were muted, and that was so that we could keep the background noise to a minimum. I just ask that you keep your voice on mute until we get to that discussion time at the end. But does that mean we cannot have a chat? Of course not. There is a chat box at the bottom right of the screen, and use that space to type in your comments, ask your questions. When we come to the Q&A part of this webinar after the presentation, I'll be starting with those chat box questions for our discussion time. Just note that if you change the send to box to say to everyone, then more people than just myself get to interact with those questions, and that will make it a more lively community discussion. So I invite you to do that. And again, this is a draft framework where the presenters and the working group is looking for a rich discussion and feedback on this piece of work. So as I'm seeing a few names that I haven't interacted with yet, so let's get our fingers warmed up. Let's start writing in the chat box. What's your name? Where are you calling in from? And how about this for a new question for those of you who've been to my community webinars before? How about you start out with name, where you're calling in from, and perhaps what you're hoping to hear today in this webinar session. So we are going to start out today with an introduction from Mesfin. Mesfin, I will give you the ball and hand it over to you. Thanks for being here, everybody.
Thank you, Sarah. Good morning or good afternoon, everybody. Thanks very much for joining us for today's webinar on World Vision Health and Nutrition Emergency Framework that is before us for discussion today. I'm sharing or facilitating today's session with my colleague Emma Littledike. So World Vision Emergency Health and Nutrition Framework, although this is an updated or a draft version of the current document, but World Vision has been responding to disasters since our organization started actually with a history of responding to the Korean War. So World Vision history is actually responding to disaster and relief in many of the most difficult places. But over years, we have grown, and in terms of the way we respond to emergencies, with the development of our disaster management process and protocols, and over time, of course, the sector are also part of the World Vision emergency response package. So today we'll be focusing on the health part, and this is basically what came out from the consultations that we have had with colleagues in terms of updating our emergency health and nutrition response framework. Just for our session today, I will speak a little bit about the background, of course, and then Emma will pick up in terms of discussion on the goal and objective, the methodologies that we've used for developing this material, and then some rollout or next step, and the people that will be taking or leading this work going forward. In general, the World Vision health and nutrition sector have often not been prioritized in emergency response for various reasons. And we know that our health program, we have had emergency health strategy and the maternal newborn child health emergency response guide, and also a framework that would help us to decide in terms of that. We call it the do, assure, don't do types of guidance for people responding to disasters. But, the practice, what has shown us in the past 10 years is that in many of the situations where World Vision has been responding, health has not always been the priority as such, as much as we would like to, for various reasons. One is because the technical specialists who should be leading this response are not necessarily on the ground on the first few days because of various reasons, lack of availability of technical staff or prioritization of sectors or other sectors or, intervention taking precedence over health. And at times, I think, there is lack of understanding in a sense in general in terms of what World Vision does when it comes to health and nutrition in emergency. And I think for many, health sounds like a medical intervention alone, where you fly in doctors to treat patients and wounded, which is quite important and necessary intervention. But World Vision doesn't necessarily do those kind of things, but we do quite a lot on health system support, as well as community system strengthening and provision of nutrition assistance and medical services. But that has not been articulated well for people to understand what is actually World Vision doing when it comes to health and nutrition. And the other is, of course, there are other medical specialized agencies who can do this job better than us, so why should you be bothered in the first place? Perhaps, you can mention about organizations like MSF, which is basically a medical specialized organization that is known for delivering health care in disaster response. But I think for us is what is our unique character and what we can offer as an organization. And this document is actually to outline and clarify what we do, what we don't do, and then how we do it, and also the people, the staff that we need in terms of competency and the resources that is needed to support the health intervention. So I will pass on the ball to my colleague, to Emma, who will walk you through the pieces of the response framework as well as the intervention, and then we'll open up for discussion later on. But feel free, please, to put on your question in the chat box, and we'll answer as we go by. Thanks very much. Emma, over to you.
Thanks, Martin. I'm just going to launch straight into the next bit. Okay, so there's quite a big space in the emergency health and nutrition sectors, often because there are specific health and nutrition emergencies, as well as the health and nutrition kind of components other kind of sector emergencies. But we went through the OPSHA financial tracking service, and you can see that kind of after multi-sector interventions and after food, health, which kind of encompasses nutrition, is the largest funded sector. And so that has enabled a lot of organisations to really expand in it. You know, like Goal and Save and IRC have all kind of grown their emergency health and nutrition programming over the last few years. And so World Vision as an organisation, you know, because we have this kind of multi-sector approach which includes health and nutrition, you know, we are quite, in a lot of places, we are pretty well kind of positioned to be able to expand. And we have, as an organisation, a really good background in health and nutrition through our kind of community-focused programming. And we have our own unique approaches. And as Meston was saying about MSF, you know, their approach is obviously kind of intensive support in inpatient care facilities for a kind of short amount of time in the initial aftermath of an emergency, whereas, you know, the World Vision approach is kind of more community focused and kind of building on existing systems. So yeah, this, I just pasted the table from the financial tracking service so that you can see where the funding requirements and pledges from 2016. So yeah, we have a really good history of health and nutrition activities in emergency responses. The first thing is, you know, we've got obviously rapid response team members specifically focused on these sectors. And one of the kind of the main methodology, I guess, before coming up with what our interventions kind of should be, was to look at lessons learned on the types of responses that we've done as an organisation, and looking at how we implement and you know, what was the strengths and weaknesses of those responses. So basically that just entailed trying to find previous staff members who'd worked on different responses and just arranged like an interview chat with them to find out kind of what they could remember. There wasn't a huge amount on World Vision Central in terms of lessons learned and information that was, there wasn't much on that, so it was mostly through interviews. And then there was also just consultation with senior staff members as well that kind of remember what happened where. So then this is just a list of examples of some of the ones that we looked at, going right back to 2008, the Zimbabwe cholera response up to Zika. So yeah, that's just kind of, this is just like a list of the sort of core components of what we did. So women, adolescent and young child spaces, and mobile health facilities, and community health promotion. So that's kind of the summary, but there's a more detailed report that has information on each of these. Yeah, so some examples of what some of the lessons learned were. Preparedness is really critical, and having solid relationships with the Ministry of Health and various stakeholders in country. Health and nutrition technical staff really do need to be deployed as first responders. There's a number of responses where they went in kind of too late and everything had kind of been divided up in terms of who was doing what and where, and it was kind of too late to be able to do much. So yeah, not having much of a relationship with the Ministry of Health prior to an emergency at the national level can create barriers. So then existing capacity of national staff and their experience of working in emergencies can also kind of affect the scale and pace of the activities. Cluster engagement was critical in terms of, you know, facilitating access and determining what we would be doing, and just to avoid duplication. Strong logistics, definitely, in terms of the supply chain with medicines and medical supplies and equipment. Adaptations in terms of remote management for some responses where we just couldn't get access. Partnership, and just, I think willingness to try health and nutrition and invest in it in places where it was a new sector, and just compliance with World Vision's procurement and pharmaceutical policy. So the actual framework, so we wanted to first of all look at, okay, what are the different disasters that could happen? How do we categorize those disasters? And also the response phase to each type of disaster. And then what would be the appropriate health and nutritional response and interventions per type? Obviously, it really does depend on the context, but we can kind of make some general assumptions. And then to look at what, the staff competencies would be required according to each type. And then to kind of define what we need in terms of operational capacity and human resourcing and commodities. So then the methodology. So I've gone through the historic responses, and then we also just went through a review of all of the project models, because some of those, obviously, like the women, adolescent, and young child spaces, are for emergencies, and just looked at what adaptations could be made, and then the framework was kind of drafted. We also did annexes on preparedness. And so far it's been reviewed by kind of key senior technical staff in the organisation, but we need to gather as much feedback as possible, which is, I guess, the reason we're having this call. And then, drafting of the actual operational capacity ideas. So we've kind of defined our objectives of our health and nutrition responses. So the first outcome is that the vulnerable groups, such as women and children, can access essential services in the aftermath of a disaster. So that really is kind of life-saving health and kind of putting on the temporary services that are required. So, mobile medical services, women, adolescent and young child spaces, IYCS services, and CMAM screening and treatment units. That's just kind of one example. The second outcome is kind of system strengthening to be not just meeting the immediate needs, but also building something longer term. So that's about strengthening like a basic package of services, so partnering with the Ministry of Health at all the levels, and resourcing training, providing them with supplies, rehabilitating and equipping health facilities, as well as staffing support. So then the third outcome was about family and community health, which World Vision obviously does really well in development contexts, but just kind of supporting families and communities to understand and protect themselves from the public health risk. So that was mainly looking at, okay, how do we work with community health workers in terms of recruiting and equipping them and providing them with training and resources, and then really supporting the community mobilisation that's required in an emergency response. And there's just some examples there of the types of support that we would be giving to community health workers. So then the fourth outcome was about early warning and surveillance in terms of disease outbreaks, making sure that we're feeding into the early warning system, the National Health Information System, and kind of making sure that everyone's aware of potential disease outbreaks and able to refer, and so that was a key outcome. And then the final one is about interagency level health and nutrition coordination platforms. So making sure that we are actively participating in the cluster and and supporting the activities and liaising with all of the other stakeholders, other NGOs, United Nations, everyone involved really. And that's so involved by way of contributing data to 4Ws and making sure that we feed our program data and what our needs are. Yeah, that's about coordination. And then, okay, so on to the actual kind of how we did the breakdown of the disasters by type. There wasn't really, we couldn't find much in kind of World Vision resources in terms of how we look at this as an organisation. So this is kind of made up. But so the first type was rapid, so that really encompasses any kind of natural disaster. And then we just kind of listed them by subtype. And then, so we have like a really estimated response time frame. Obviously, it's completely different by kind of the type and scale, by the scale of what the emergency is and how quickly everyone's able to respond. And then, so the second type was kind of more slower emergency. So really looking at drought and famine and displacement, and that again, the response time frame is really just an estimate. So the third type we put complex, mainly referring to conflict types of emergencies, and again, it's an estimated time frame. And then the fourth, I guess, is a specific health emergency would be disease outbreaks. So yeah, and that the response time is kind of here counted from where the point of declaration. Okay, so I've just kind of pasted in like a kind of images from what the framework looks like, because it's too massive to really present all of the components of it. So we just want to give you a visual of how it kind of looks as a document. So this is kind of laying out what would the anticipated needs be in a rapid emergency. Again, of course, like it's different according to the context, but it's kind of just general assumptions. And so yeah, you know, the 0 to 72 hour phase to 1 month, we've kind of said, okay, what we would do by way of assessment and the planning and coordination that happens and the kind of rapid initial activities in that phase. And then we're always looking at the intersector linkages with each section. But then the same thing with the continuing response. You know, what do we do by way of response activities and coordination for that phase? So it's literally just a list of like activities and interventions that we could potentially do, or that's recommended or that we've been doing. And then there's like a phase out bit. So each section, so that's just for rapid, but it's like that for each section, for the slow, and then for the complex, and then for the disease outbreaks. So then other components accompanying it. So we've got these annexes on preparedness. They're quite short. They're just a page each of kind of recommendations of what a national office can be doing to in preparedness, you know, by way of liaison with the Ministry of Health and making sure they're familiar with the disaster management kind of strategy and documents in the Ministry of Health, and just in terms of kind of positioning in the right way. So that's all, again, those annexes are by type, so for the rapid type and then for slow and complex and disease outbreaks. And so, yeah, also we're looking at kind of triggers within that and how we do surveillance and coordination. So then, yeah, then we have like recommendations on human resources and operational capabilities that we would need. So this is just a quick, small kind of flow chart showing, okay, it's really critical that we have GRRT health and nutrition staff deploying in the first phase, and kind of what broadly that they would be doing in each phase. So yeah, I guess in the first bit, having that cluster engagement, doing the needs assessment, and rapid networking to the second bit in terms of designing the response and liaising with the technical donor reps and more in-depth assessments and recruiting staff, and then how it progresses then to the continuing response in terms of people arriving for the longer term response. So then, okay, so this is just kind of showing like who would go by type, because for like a slow onset where it's a drought or a famine, you'd obviously prioritize the nutrition manager to deploy, whereas for, say, a disease outbreak, obviously the health manager would be prioritized to deploy. And so just kind of looking at how we prioritize who goes, knowing that there's not always enough resources to be able to send like a whole nutrition team and health team. It's just, yeah. So then, this is just a snapshot of the competencies, just an example so you can see what that kind of looks like. So there's sort of, okay, what do we need from them in terms of technical leadership, and what skills do we need, what attitudes do we need from the people that would be first responders. So then in terms of operational capabilities, so looking at things like, warehouse space for pre-positioning, storage of, all of the medical kits and supplies that we would need, and then funding for the surge deployment of technical staff, and then just making sure that supply chain, that the right kind of mechanisms are in place that we'd be able to, get the supplies to there as quickly as possible, and then just improving our kind of response roster of technical staff. So looking at not just the GRRT, but who we have where that can deploy, and what trainings people need, and this kind of thing. So then the commodity packages, we've literally kind of gone through and done like detailed lists of all of the medical kits that are needed, all of the pharmaceuticals, like all of everything that you would ideally might need to send. Obviously they can be refined, things can be taken off or added according to, the specifics of what's needed in a response, but just having it kind of there with detailed specifications so that that is a resource for procurement. And then, okay, so then just on rollout and the next steps, it's quite difficult at the moment to establish this because there's a lot of restructure going on and changes in World Vision. So I guess the first step is just getting feedback from this group to make more changes that might be needed, and then to determine what the TSO, Technical Services Organisation, would be, how they would be involved, and then to look at the sharing these documents more widely with the right people in the organisation. And then, so key focal points are mainly the HEA team and MESPIN at the moment. So I think that's the end. So, which is good because then we have lots of time for our discussion.
Thank you, Emma, for walking us through what this framework entails, which is clearly has been a review on what have been the best practices and some gaps in our previous responses. So at this time, we do have quite a bit of time to open this discussion, and there is a lot of discussion to be had already in just some of the initial questions that came out of some of our introductions. However, I will also remind you this is a time where you can continue to use that chat box to write in questions and comments in this discussion. I see that we have several members of our rapid response team and the health, nutrition, and emergency interest and working group leads are all here. If you have something you would prefer to ask with your voice instead of typing it down, please use the raise hand feature, which to the right of your name, there should be a little photograph, a little icon of a hand. You can use that to indicate to me that you would rather voice your question at this time. So Emma and Mesfin, I'm going to dig in first with, there were several questions in the chat box around what about expectations for integration with different sectors. An example might be around early childhood development in emergencies, with resilience teams. What are the dependencies on other sectors that are expected to implement this framework? Mesfin, maybe I'll pitch that one to you.
Yeah, thanks, Sarah. Yeah, and I think that would give some break for Emma. So thanks for that question. I believe it came from our colleagues from Livelihood. In fact, World Vision strength actually is on our ability to do multi-sectoral programming, both in emergency as well as, of course, development. And the emergency framework actually outline or articulate those sectors that contribute to health outcome. And mainly we picked issues like wash, water, sanitation, hygiene, and of course food and food assistance, which is quite essential for meeting the nutritional need of the household or family, and as well as early childhood care and development, and the work we do around child protection. So, we didn't go into much detail in terms of what those integration would look like. And I think the key point here is that, the project model that are listed in the emergency response framework, one is WEX, which is a women and adolescent young child space where early childhood as well as breastfeeding support and creating a space for mothers and adolescents. That model brings that level of integration of different approaches to deliver for that target group. And again, the same with the CMAM program that we have identified in the framework as one model for responding for high level of acute malnutrition, where we think that child stimulation and early childhood care, it should be part of the nutrition feeding program that we do. So I think the details are in the document itself. This is a framework that kind of outline the key issues that is addressed through different models, and then also identifying the key models that bring this integration, like some of those that I mentioned, like CMAM, like the health facility or the WEX, or those spaces that we think would deliver integrated service. So that's where we see, and I think the document clearly puts greater focus on the multi-sectoral integration point, and at the same time what we do with communities, but with a focus again with a primary care or primary level service, and facilitating referral to secondary, tertiary care. So as such, the framework doesn't necessarily put much emphasis on tertiary care, which that is not World Vision competencies, but we made clear linkage that referral to access to services for things that require specialized care is one of the key actually enabling or intervention area for World Vision. So yes, there is a lot of areas of integration. I think I invite you actually to read the document, and we'll be pleased and happy to get actually detailed feedback so that we can enrich with those points that you have just outlined. Thank you very much.
Mesfin, perhaps moving forward on the top of that, as we're inviting different sectors within World Vision to come forward and provide their input on how to better link with their sectors, we acknowledge that within World Vision we have several structural changes. What are the next, and one of the questions coming from the chat box are, what are some of the next practical steps in implementing this change of framework into World Vision?
Again, on that point, we have worked this document in collaboration with HCA, our Humanitarian Emergency Affairs team, where Claire Beck will be leading this discussion in the next WebEx, leading the technical team, and Ando and the other operation team who have been quite heavily involved in the development of this framework. So it is a joint work, although the health team led on the technical content and the framing and the development of the product. And I must acknowledge here as well that Emma, who just did the presentation, is the one actually who have been leading this work. So, excellent work, Emma, for getting us thus far. So we are planning to use this framework as a way of for staff competency development. I think on the framework, we identify the competency needed to deliver the services. So then that is the same framework we'll be using for equipping and training our human resource to be able to deliver on what is being outlined in the framework. So that is one area of work, I think, continue going forward. And we will be working in terms of fleshing out the details of what is the commodities, the pre-positioning that is needed, in terms of the prioritization of the sector itself, so orienting, leadership and operation staff who are always been the decision maker on the ground. So we are aiming to do this jointly with HCA, and that will be, the work that will happen in the coming months or years to come. So I see that quite a lot of comment. I think I will speak to some of them, and maybe Emma, you can comment on others that I may have missed. So I think the question about on linkage with government approaches and protocols, I think that's a very valid question. I think emergency response by nature, I guess, there are quite common feature in many of those situations. And many of the services that are provided are actually known that, we don't have to recreate, things or so we can apply the learning that we have based on the context that we know. But again, as always, our approach is actually to work with the local community as well as the government to ensure that we are responsive to the local needs, and it's also supporting the health system, not necessarily coming and establishing a parallel system that would undermine the local health system. So we'll work with the local health system. I think that supporting health system is quite at the center of this framework, and working with the government is certainly the way we do our work when it comes to emergency response. So I will stop there. Emma, anything that you would like to add?
There's a lot of questions. I'm just looking through to see if there's anything. Maybe, does anyone want to ask it out loud? Just because it's going to take me a while to look through all this chat.
Yes. Emma, I could also help a little bit. All right, so there was a question from, I think it was from Anthony, about what about guidance for setting different goals for each disaster type? As you did this reflection, and you said we've outlined the 4 different disaster types for the first time within World Vision. Was there any discussion about World Vision specific objectives and goals for each of the 4 disaster types?
Okay, so the kind of the outcomes that we went through at the beginning were kind of the broad, that's it kind of broadly. Like we didn't do kind of goals per type of disaster. It's kind of feels, each section kind of feels too big to kind of narrow down. And I guess also because it would be different by context. So it was also kind of looking at, this is just like a list of possible stuff that we could do, but it's not like we might not be doing all of it, because it might be that, like if it's an earthquake somewhere, it might be different from another type of disaster somewhere else. So the actual like narrowing down would be different by context. So it's kind of more overall broad goals, really. I don't know if that answers your question okay, but
thank you.
Oh, go ahead.
This is Anthony. Thank you for the answer very much. Just exactly what Sarah explained about that. That was in my mind. This particularly when you were talking about only the 4 type of the emergencies. Whenever come to the particularly nutrition sector, so we have to focus on the pre-disaster nutrition situation in the country also. So whether I was wondering whether it is going to be collaborate with that kind of decision-making tool also here, or just we are going to go with only for these 4 types, which is not really going to be helpful for us only to take decisions.
Yeah, hi Anthony. So there's like so for the nutrition side, for the slow onset emergencies, the kind of preparedness annex that goes with that is more maybe focused on what you're saying in terms of surveillance, and so looking at the GAM level and IPC score and that kind of thing. But it does need probably to be more detailed, like fleshed out in more detail. But I can send it.
It is also for the rapid onset. Also, it is maybe applicable because we need to think about it first. What is the situation of the country before we make a decision on the nutrition program, rather than when we want to just concentrate on the CMAP. That is depend on the, as you know, the GAM-SAM rates. So that's why my questions. Then we can discuss more on that later. Thank you.
Yeah, so in the kind of, I guess in the actual framework, it does kind of, there's lots of exceptions. It's like if this level is above emergency threshold prior to X, Y, or Z, there's kind of that wording within it. But yeah, it would be good to have more detailed feedback from, how maybe we can change that wording if needed.
Thank you.
There are a couple of questions here around what has been the guidance around accountability streams within the different emergencies. Could you perhaps give some examples from the lessons learned review that you did, Emma? And another question around what are the guidance around monitoring emergency response in this sector moving forward?
Okay, so I'm trying to, it was quite a long time ago that I did the lessons learned document, but there was a lot of more broad lessons learned, things like in the Haiti response, the fact that we didn't deploy sector staff until maybe, well, it was definitely not in the first few days, but it was maybe a few weeks in that we had sector staff go, and then there wasn't the space to be able to move into implementing health and nutrition programs because it was kind of already divided up who's doing what where, and most of the activities in those sectors were already underway. And also looking at things like with the women, adolescent and young child spaces in Nepal, there was a lot of barriers because in Nepal, they were known as kind of breastfeeding spaces, and so like the different terminology that we were using, it took a long time to kind of get the government approval to be able to roll out the amount that what we wanted to, and also just in terms of orienting that the staff in Nepal with emergency programming was quite a long process as well. So it was it's kind of quite practical lessons learned. And then in terms of the accountability, there isn't really anything on beneficiary feedback mechanisms. obviously, like that's something that we have looked at before, especially with remotely managed emergencies, like with the Syria response, having you know, beneficiary feedback in health facilities. To be honest, it was just really, really limited, the information that was actually available. There was barely any documents on World Vision Central, and even trying to find specific program reports that we had done was very, very difficult. So yeah, I mean, there's not, it was, and I guess going through interviews with the staff members, I was trying to kind of harness what I could from their memory, like, because a lot of the time it was however long ago, or they just were there short term, and these kinds of things. So there's probably a lot more that could be done to look at that and incorporate. Yeah, I don't know, Mesfin, I don't know if you want to add anything.
No, I think you've articulated the state of play on that, so thanks, Emma. I want to make a comment on the gap. I think there's a question asked at the end of this chat box. I think you know, there are quite a number of areas certainly in terms of gap that requires research. Perhaps you know, some of you might know we are currently looking at with HA in terms of the health benefit of multipurpose cash programming for emergency response in terms of health outcome. And that is quite a new area in terms of cash-based programming. And we know that World Vision is doing cash for food purpose, and in some areas for you know, other sectors. But I think the cash for you know, food is quite straightforward. But I think for health outcome, we don't have much evidence. And as such, certainly in World Vision, our experience is not there. So we are actually, you know, presenting a research concept paper to do that in collaboration with the WHO and academic institutions to get funding to look at the health outcome benefits from multipurpose cash programming. So that is one area that we think where the humanitarian system is heading, and where we think there is potential for World Vision to use cash for health, even for other sector for that matter. So that is one just example that is currently happening. And certainly emergency health is an area which is less researched, if I may put it that way. From many of our examples or experience are from health programming or humanitarian response in refugee camp settings, where people are living in a certain organized camp where everything has to be provided by humanitarian agencies. But now we are seeing increasingly refugees are living in urban settings, like the Lebanon response that we are doing now is an urban programming. And Haiti, that what Emma mentioned about, was an urban programming. You can continue on saying all the Asia you know, emergency response we responded was in urban. So in that context where people are not necessarily in the classical relief camp, and how do they better deliver service, and then what would be the delivery model even for that kind of context. So there is an emerging trend that we have to be responsive in terms of how we approach humanitarian response, which has direct impact in terms of our health response. So we are looking at those things and see, you know, how better prepared and even build the evidence base to be able to be relevant and continue to be providing the appropriate response for people affected by humanitarian disasters. Thank you.
Mesfin, there's another question here, actually for Emma, and I see others from our HEA team here, about a gap, specific around the gap of humanitarian technologies, technologies that support these efforts. So what further research is needed, or what further guidance is needed to address technologies? And we have Salma from Nigeria who's joined the call to talk about how mobile technologies and their response are useful. So what gaps were found in humanitarian technologies?
Emma, do you like to say something? Okay, go ahead.
Yeah, I'm just thinking about that. So there's nothing, I guess there's not really anything in this framework that specifically references, you know, like mHealth or, you know, I'm thinking about other technologies like, you know, DHIS2, or that we haven't specifically referenced that. There is obviously a component of how do we do surveillance and monitoring, but obviously it would depend on what is in place in the country or what is being put in place, and I guess what's kind of decided by the cluster. Or so, I mean, like the same with accountability. Like this, if this is an area where we can get extra input from people in the partnership, that would just massively enhance the whole thing. So yeah, if there's any ideas on that, that would be really good.
Hi, Emma, can you hear me?
Yeah.
Oh, fantastic. This is Dr. Salma. I think you've done a fantastic presentation. It's really amazing. And I think the question on humanitarian technology is a great one for addressing some of the issues that you mentioned, especially in the context of the surveillance and monitoring and being able to coordinate and integrate the work that is going on. We're working at the moment with some of the IDPs, so the issue that was mentioned about the changing environment and finding the safe space is really critical for us, because we have many cases of severe and acute malnutrition. So one of the things we've been looking at is how to identify where pregnant women are, identifying the different vulnerable groups. And actually, with the mobile, you can actually identify the exact location. So when you're trying to distribute aid, you can actually reach them and at least get close to the proximity of where they are. But I think it's a tool that you find pretty much, at least within clusters of groups, people have access to smartphones, and that really helps you keep current on the data that you need, both at the main base, but actually at the remote site where you're working at the edge in the conflict areas.
Yeah, that's great. Is that the same? Because there was a tool, I was looking at something that was done by Concern and Instead, and it was like a tool for mapping women with potential obstetric emergencies, looking at mapping pregnant women in the communities and using mobile phones. And I mean, I know that there is a lot going on with all of that, but it's not kind of incorporated enough like into this framework. I know even like in the Philippines there was a big project with drones that was looking at using OCG mapping. So I don't know, like maybe, yeah, if this can be kind of enhanced with information about what we can do with those kinds of technologies, then that would be really good.
Yeah, I think it can be very easily integrated into the framework that you've got there, into the key areas. It's not the same one that was done with Concern. We're actually working with it. Sorry, really with the Ministry of Health, and what we're trying to do is identify complex cases of pregnancy with ultrasounds, very simple devices that can identify if there's immediate referral required. It's a complex case that can actually save the lives immediately without having a super qualified health practitioner on ground. So I would like to give you some comments back on your framework.
Yeah, that would be brilliant. Thank you. Fantastic.
Thank you, Dr. Salma. Claire, I saw you had your hand up.
Yeah, I did, because we don't actually have any technology ourselves other than the LMMS system, which is a beneficiary tracking system that they use for cash programming and for making sure we have beneficiary lists. And so we have been talking about how we can link that both to any mobile services that we might offer, but also to specific groups. So that would at least enable us to identify where people are and what their basic needs are. We've been talking to a number of groups about health information sharing, so how we could get health information out on mobile phones. So a bit like what they did after the Zika response, where WHO put out an app for information about Zika, so that's something else that would be really useful, especially as much of the work that we do is at the awareness, preparedness, primary healthcare level. So reminding people to have vaccinations, reminding people when vaccination teams are coming through, trying to help people get registration, birth certificates, etc. So there is opportunities, but we don't actually have very much within our own system. The other thing we've looked at too is how do we actually have a better information management system around tracking of patients if we are doing clinics, and linking that back into Ministry of Health databases, and also stocking of clinics, because our normal commodity staff do not like medicines because they're small items and many of them, compared to bags of food where there's large bags and not many choices. So a lot of our warehouse staff are not used to working with pharmaceuticals. So it's things that we're looking at, and we're talking with some of our IT specialists, but we haven't got very far yet.
Thank you, Claire. I am looking, we've done an excellent job, everyone, for going through the chat box and having help people answer questions. All right, I'm going to pause to see if we have other burning questions. We have time maybe for one or two more, and then we'll do some wrap up and some announcements. So I'll pause for a minute. So any burning questions, raise your hand. Dr. Salma, I see your hand still, but I think that's from before. All right, so as we come to the top of the hour, and hey, closing in on time, which is also a good thing. From this discussion, we've talked about what's in this draft framework. We've heard commentary that there could be future discussions on integration components and how this better links to other pieces of different sector response strategies. We've talked about looking and furthering guidance on accountability pieces within this framework, as well as interested in perhaps discussing and moving forward technologies for humanitarian response. As Mesfin has said, we are looking for feedback on this draft. This, of course, is being recorded, and the primary stakeholders in this working group are participating in these calls to hear your feedback. But if you would like to provide some written feedback to the strategy, what I'm going to do is set this framework up in a space where you could provide comments online on WV Central. Or if you, yeah, so let's get those comments going and continuing on our shared health and emergencies interest group space. I just want to say thank you very much to Mesfin and Emma for leading us through this conversation today. And Claire, who has joined us at this call, will be leading us at 11 p.m. New York time. I need to look at, I forgot to look at what time that is going to be, GMT. So in about 13 hours from now, we'll be going through this presentation again for the other side of the world. So if you have a friend that wasn't here today that you feel like should be part of this community call, invite them. We've got a time number 2. And just a few announcements here. We do have our Health and Emergencies resource page on WVI.org and on WV Central. Those links will be circulated in the follow-up article. And there is something new that we're doing within this community of practice. We are piloting a nutrition drip course. What is a drip course? It is a micro-learning course. We have 2 courses going on starting from right now to mid-March. Introduction to International Nutrition and Introduction to Maternal, Infant, and Young Child Nutrition. So what is a micro-learning course? It's email-based e-learning, where you get one email a day for a series of 8 or 9 days, depending on which topic you choose here. And it's about 15 minutes of reading and a video link. I got my first day number 1 for both of these courses yesterday. We're trying this out for this community of practice. If you would like to participate in that pilot, there's a link. You can quickly write it down on the screen. I'll paste it in the chat box in just a moment. Join us, and we'll have a discussion and get feedback on how we like this new form of learning. Coming up, I'm just putting on the screen our next webinars coming up in February and March. We, again, are having time number 2 later today. Later this month on the 28th of February, we'll be joining the education community of practice as we're doing an overall competencies orientation for World Vision. And on 17th March, we'll be celebrating 2 years Ebola-free in Sierra Leone. It's been 2 years since Ebola-free, but we are still learning from our programming response during that epidemic. And we've just released 2 new Ebola reports, which were in your last Community of Practice newsletter. So come and learn alongside those stakeholders. All right, that's it for me. I just like to say thank you for being here, and we'll see you on the next WebEx. Bye, everybody.